Hello, my name is Paul Friedman. I'm chair of the Department of Cardiovascular Medicine, and I have the pleasure of being joined by my colleague, Dr. Abou Ezzeddine, who is the director of our Cardiac Sarcoid Clinic, as well as a cardiologist with expertise in nuclear imaging. Dr. Abou Ezzeddine, thank you for joining us.
Thanks for having me, Dr. Friedman.
So let's start with the basics. What is cardiac sarcoid?
Sure. Well, sarcoidosis is an autoimmune process, and cardiac sarcoid is when sarcoid, which is an autoimmune inflammatory process, infiltrates the myocardium. Some are refer to it as sarcoid myocarditis. And it's a process where either the etiology is actually not clearly defined, but expert consensus believe that it occurs because of a certain patient population who have a genetic predisposition are exposed to a certain antigen. And this antigenic exposure in this predisposed individual results in a systemic inflammatory autoimmune process. Typically, it affects the lymph nodes, including the hilar, mediastinal lymph nodes, among other organs such as the eyes, the skin, and the lungs, obviously, even the kidneys, and ultimately also the heart is involved, which is why we're talking about it today. Increasingly recognized is the process of isolated cardiac sarcoid, where actually the heart is the only organ that is affected. And recent data suggests that 25 to 50% of our patients may have this, and an even larger cohort of patients may have it that is in a situation which is unrecognized. So they have the symptoms, the presentation, and they're only recognized on autopsy, actually, of having this process of inflammatory cardiomyopathy.
So let's talk a little bit about the symptoms, and more broadly, when should we suspect it and when should we actively look for it?
So, excellent question. The reason this is a very difficult disease to diagnose is it's one that can present with no symptoms and a coincidental ECG finding, for example, or symptoms that are prevalent amongst all of us, such as fatigue and occasional palpitations. But typically patients come to our clinic when they've been identified to have certain high-risk features, such as syncope, ventricular arrhythmias, high-grade AV block, unexplained cardiomyopathy. Those are typically the symptoms which garner enough testing, if you want, to elicit the diagnosis. But increasingly, we are appreciating that patients present with sometimes minimal clinical cardiac symptoms, if you want, however, supportive imaging. And it's this diagnosis that makes it quite difficult, because it's, it takes multimodality imaging, which we can talk about here in a bit, in conjunction with a clinical history to really identify these patients. Further, historically, we have learned that cardiac sarcoid is a diagnosis of exclusion. So while it should be on our radar, there's a lot of other much more common differential diagnoses that need to be ruled out or not overlooked before we hone in and say that this patient has cardiac sarcoid.
So what are the top things that are on that differential? What are the things we're thinking about?
Sure. So, all things being common, patients with who, for example, present with cardiomyopathy, we need to make sure that particularly if they're younger, we need to make sure that genetic cardiomyopathies, genetic arrhythmogenic cardiomyopathies are ruled out. Sometimes certain findings on echo imaging is pathognomonic, if you want, dare I say, for sarcoid, such as aneurysms at the base. But before, if you're seeing a patient that has multiple comorbidities for coronary artery disease, that needs to be ruled out before you go down the trajectory of sarcoid. We have seen patients that have been referred to the sarcoid clinic who have never had coronary angiograms done, and actually, in retrospect, had severe coronary disease that had certain features that made one think of sarcoid. So typically we need to think of genetic cardiomyopathies, particularly in the young, arrhythmogenic cardiomyopathies, and coronary disease. And then once those have been ruled out, then we need to really start thinking of possible myocarditis, such as sarcoidosis, which is one of those myocarditis. Typically, these patients have more of an indolent chronic presentation rather than that of an acute myocarditis, though possible. So the big thing, when you see a patient with an acute myocarditis with hemodynamic instability and arrhythmogenesis, you need to be thinking of giant cell myocarditis, and the diagnosis needs to be made within hours with a biopsy and aggressive immunosuppression. So we don't want to overlook those more common diagnoses in the differential when patients present acutely. But if a patient has had that workup and they're more stable, they're in the outpatient setting with a indolent cardiomyopathy or heart block or whatnot, then we need to be thinking of those of sarcoid myocarditis, if you want.
So you see a patient in clinic who has, say, some thinning of the septum at the base on an echo. They've had an episode of syncope. There may be some conduction abnormalities on an ECG. And you're starting to think, I better exclude sarcoid. Don't know yet, but I need to exclude it. What are next steps? What's your diagnostic cascade?
Sure. The tricky thing about sarcoid myocarditis is it's a patchy process which infiltrates the myocardium in a very patchy way. It could affect the right ventricle, but more commonly, it actually affects the left ventricle. It can affect the endocardium, but more commonly affects the mid and subepicardium. So all these things, left side, mid subepi, patchy, make it very difficult for a bioptome or for endomyocardial biopsy to make a diagnosis. In fact, the yield of endomyocardial biopsy in this disease process is only around 20%. There is recent data that with voltage-gated mapping, the yield increases to 40 to 50% perhaps, but still not a great diagnostics tool.
So just for our listeners, what you're referring to there is EP-like mapping, where you look to find areas where the voltage is small or the signals are fractionated and chaotic, suggesting infiltration and biopsy there.
Exactly right. So because of that, we have the diagnosis of definite cardiac sarcoid is only made if you have non-caseating granulomas that are seen on endomyocardial biopsy. And that's the pathognomonic pathologic finding. If you've ruled out mycobacterial infections on that specimen. But that is the exception rather than the rule. Typically, we're increasingly seeing diagnoses of probable cardiac sarcoid. And what that means is the patient has extra cardiac signs or extra cardiac manifestations of sarcoidosis, such as hilar adenopathy, biopsy-proven pulmonary sarcoidosis, or dermatologic or skin sarcoid. And then you investigate further and you non-invasively make a diagnosis of cardiac involvement. And those are the cohort of patients which we call probable cardiac sarcoid. And so that brings me to the non-invasive, if you want, supportive imaging, which we rely upon. There are two main criteria and these are consensus expert-driven criteria, if you want. One from the Heart Rhythm Society, which whereby you need to have for the diagnosis either biopsy proven, so cardiac biopsy, definite, or extracardiac biopsy with certain clinical features, such as unexplained cardiomyopathy that's response to steroids, unexplained heart block, high-grade AV block, ventricular arrhythmias, certain PET imaging and MRI findings. And increasingly, there's been a push towards the incorporation of PET imaging, and they have actually made it to those, if you want, consensus diagnostic algorithms, whereby on PET imaging, we perform a specific sarcoid protocol where we prep the patient in advance to change myocardial substrate utilization from glucose to fatty acid. And then we use an FDG or a glucose-based radiotracer. And when we find that that is taken up in a myocardium that has been, quote unquote, prepped with a ketogenic diet, that tells us that this is reflective of inflammatory cells. And if you have the FDG what we call FDG uptake on the myocardium on a PET scan, in combination with perfusion abnormalities in that same distribution, the specificity of that finding is quite high for an inflammatory process such as myocarditis. There now you have, if you want, extracardiac tissue that says you have non-Casein granulomas and a diagnosis of sarcoid. You have a PET scan which shows active inflammation. Now you can more readily make a diagnosis of probable cardiac sarcoidosis in a patient population that obviously have presented with either heart failure, ventricular arrhythmias, or high AV block.
So clearly there's an important role for FDG imaging in this diagnosis, but is there also a role for MRI? And when would you pick one versus the other, or do you need both?
Cardiac MRI is an excellent modality, particularly when we're assessing myocardial morphology across the board of cardiomyopathies. However, the caveat is cardiac MRI assesses for late gadolinium enhancement, and it's very difficult to differentiate scar and fibrosis from active inflammation using this technique. That being said, there are new protocols, and the technique is really advancing, that now we have T2 weighted imaging, which actually identifies myocardial edema. And so there are these edema sequences where you can actually identify if there's active inflammation. That being said, this technique is site dependent. Not all of the centers, not all of our centers are strong in MRI or have had experience, if you want, with MRI, particularly these novel techniques. So typically, when we speak to the community as a whole, while cardiac MRI could identify late GAD enhancement, which is suggestive of scar or fibrosis, you really need, we believe, FDG PET imaging to identify inflammation, because you could have low-grade inflammation that is not at the level that the cardiac MRI is sensitive to pick up. So there's an increased interest, if you want, with hybrid PET MR imaging, whereby we can look at the MRI for scar, but also look at areas that seem to have a signal of edema, and look at it under PET imaging and see, oh, indeed, this area that appears edematous on MRI actually has FDG uptake on PET, and there may be inflammation there. So that's the ultimate goal, is to move towards a multimodality PET MR, if you want, a technique where using hybrid imaging, you can identify both scar and inflammation and help with these diagnoses clinically.
So obviously identifying inflammation is important for making the diagnosis, but also helps inform treatment, because Absolutely. We want to block inflammation. So what are the treatments? Why is it important to make the diagnosis?
Yeah, so our colleagues here talk about this being this phenomenon of myocardial inflammation being like a brush fire phenomenon, because you have a lot of inflammation that's occurring, and that in and of itself causes scarring. It infiltrates the conduction system, causes ventricular arrhythmias, cardiomyopathy that sometimes is irreversible when the myocardium is scarred. So ideally, we identify this inflammation early on, and we intervene upon it prior to severe systolic dysfunction and arrhythmias developing. As far as therapy, to date, there really hasn't been these large randomized controlled trials of therapy that would suggest that treating with this agent or that is more effective, if you want, than not treating. In fact, we don't know if how the clinical course of cardiac sarcoid is affected by treatment. But as you can imagine, these treatments are all immunosuppressive based. And so we typically, here at Mayo at least, start with a concomitant steroid and steroid sparing agent. So as the steroid takes effect, immediately, the steroid sparing agent may take a few months to be effective. And over the course of those few months, we then taper off the steroids because of the side effects of long-term steroid use, and keep patients on the steroid sparing agent for certain periods of time to quell the inflammation, albeit treating their arrhythmias, of course, treating their heart failure with heart failure guideline-directed medical therapy, as we would to non-ischemic cardiomyopathy. So that is our current approach here at Mayo, and that sometimes goes hand in hand again with antiarrhythmic therapy and device therapy early on, particularly in patients who have high risk of sudden cardiac death.
Yeah. Well, Dr. Abou Ezzeddine, thank you for this very informative overview. There's clearly a lot happening in this space. It's continuing to evolve. And it clearly involves a lot of specialized expertise, both for immune suppression management, arrhythmia management, heart failure management, but an important diagnosis to make that can have a big impact on the lives of our patients. So thank you for sharing your expertise with us.
Absolutely. Thank you, Dr. Friedman.